Hello and welcome to the latest edition of the Radiology Advances podcast. Imagine it's late at night. ER is busy. Patient comes in, possible stroke. Non-contrast CT reveals intracerebral hemorrhage, and the neurosurgery department is meticulously interested in the dimension of the bleeding. You know, every single second is critical, and figuring out the bleed size on CT manually can take time. Minutes at least, often very valuable minutes. Other simple methods tend to overestimate blood volume, which isn't optimal for streamlining ideal therapy. Today, we're going to discuss an important article published right here in Radiology Advances. It's titled Cross-Institutional Automated Multilabel Segmentation for Acute Intracerebral Hemorrhage, Intraventricular Hemorrhage, and Perihematomal Edema on CT. The work is from Jawad Nawabi, Georg Lucas Baumgartner, Tobias Penzkofer, and colleagues. It is a multicentric study involving colleagues from 4 university hospitals in Germany: Hamburg, Berlin, Munster, and Freiburg. Additionally, doctors from Pavia and Brescia, Italy, and Basel and Zurich, Switzerland were involved. Okay, so our mission today is, let's explore how this cutting-edge deep learning model might really be changing the game for quantifying intracerebral hemorrhage, ICH, intraventricular hemorrhage, IVH, and perihematomal edema, PHE, on CT scans. And it's not just about going faster, is it? It's about precision that could really impact patient care.
Exactly. What's so critical here is that getting those volumes right for the ICH, the IVH, the edema around it, well, that information guides treatment. Is the patient eligible for surgery? Is anticoagulation reversal justified? You see, multiple questions come to the clinician's mind. Precise volumetry helps us to make the right decision, see if treatment's working, and it helps predict how the patient might do. Right now, we often rely on manual segmentation, which is slow, or that simplified ABC/2 method.
Hold on for a second. I'm sure not every listener is familiar with the ABC2 method. Can you explain it briefly?
The ABC/2 method is a quick mathematical approach to estimating the volume of intracerebral hemorrhage. It is defined as the product of A, greatest hemorrhage diameter in the axial plane, B, hemorrhage diameter at 90 degrees to A in the axial plane, and C, craniocaudal diameter, finally divided by 2. This is approximating the more complex formula of ellipsoid volume. But it frequently gives you bigger volumes than are actually there because of the non-pure ellipsoid architecture of hemorrhages. This issue could potentially skew clinical decisions.
Right. Thank you. Faced with these challenges, what did this international team actually do? What's the core of their solution?
Well, they took a specific deep learning model. It's called NNUNet, and trained it for the specific tasks. Think of an NNUNet as like a very smart, self-adapting tool for medical images. It's designed for automated segmentation and has its strengths in specifically picking out multiple lesion types on medical images. They did this retrospectively using data from 4 different stroke centers. They trained it on 775 CT scans, then tested it rigorously on 189 scans, followed by a both internal and external validation on separate datasets. Most importantly, the algorithm has either never seen the validation data before, but was trained on data from that specific site, internal validation, or wasn't even trained on data from that site, which is referred to as external validation.
Okay, and this is where it gets really interesting, especially for those involved in daily emergency care, thinking about working in a busy clinic. The time savings. The automated model, it processes cases in, get this, an average of just 18.2 seconds. This is astonishingly fast compared to the manual segmentation method, which they clocked at 18.01 minutes on average.
Just seconds. That is a massive difference.
That's a genuine game changer for how quickly you can get crucial information in an acute setting.
And it wasn't just fast, it was accurate too. The performance was really robust. Detection sensitivity, such as finding the bleeds, was super high, 99% for ICH and the edema and 97% for the IVH. And for actually segmenting them, the accuracy measured with the DICE score was 0.91 for ICH, which is excellent, 0.71 for PHE, and 0.76 for IVH, still a very strong result. High dice scores, particularly that 0.91 for ICH, mean the network segmentation is incredibly close to the experts.
And if you take a closer look at the volume differences between the automatic segmentation by the NNUnet and the manual reference standard, -5% or -0.62 milliliter for the ICH, 12% or 0.57 milliliter for the PHE, and -1% or -0.87 milliliter for the IVH. I suppose those deviations may be clinically irrelevant. Speed matches top-notch accuracy. Great to see that. But the big question with AI, the elephant in the room, is always generalizability, right? How well does it work across different hospitals, maybe different scanners? And did it struggle with anything specific?
That's a key point. And the good news is it showed strong generalizability. By design, the risk for an overfitted AI model in this study was very low, as they included data from multiple sites and vendors for the training. The external validation yielded a median DICE score of 0.85 for the ICH. That precision is crucial for real-world use. Interestingly, even if other types of bleeding were present, like subarachnoid or subdural hemorrhages, it didn't really throw off the ICH segmentation much. But it wasn't perfect everywhere. Very small IVH volumes or bleeds located deep in the brainstem, those were a bit more challenging for the model to segment accurately. For instance, the median DICE score for brainstem ICH dropped to 0.70. Still, brainstem ICH only accounted for 5% of the ICH locations in the training and test set. For edema, misclassifications occurred due to density overlap with hyperacute ICH or adjacent microangiopathic alterations of brain tissue. The main issue for IVH misclassifications was the anatomical overlap or morphological similarities to choroid plexus. So, there are still areas to refine, but the overall performance across the board was remarkably strong.
Okay, so let's wrap this up. What's the big takeaway for you?
Essentially, this study gives us a very powerful, automated deep learning tool. It's reliable, it's efficient, it segments these crucial hemorrhage components on CT scans accurately, and importantly, it's been validated across different clinical settings. This could really streamline things, give you precise data fast, and may free you up to focus on the bigger clinical picture. And it makes you think, doesn't it? As artificial intelligence tools become more common in our workflows, well, how is that going to fundamentally shift our approach? We've talked about rapid diagnosis, but what about using it for tracking changes over time or even predicting recovery? What new doors might this open for managing patients beyond just that first scan?
A fascinating question for the future, and that's our Radiology Advances podcast for today. Thanks to Nawabi, Georg Lucas Baumgartner, Tobias Penzkofer, and colleagues for publishing their study on accurate multilabel segmentation of brain hemorrhage with Radiology Advances. If you found this episode informative or have any other feedback, please rate, review, and subscribe. It helps more people discover the podcast and supports the broader conversation around innovation in imaging. You can read the full article and explore more great content on the journal website. Remember, Radiology Advances is open access, and we are proud of contributing to the removal of barriers in science. This episode was generated with the help of AI, but all content was reviewed and verified by editor Dr. Lukas Salhofer from University Hospital Essen, Germany, for accuracy. Thanks for joining us. See you next time.